Doctors with disabilities exist in small but impactful numbers. How do they navigate their journey? What are the challenges? What are the benefits to patients and to their peers? And what can we learn from their experiences? Join us as we explore the stories of doctors, PAs, nurses, OTs, PTs, pharmacists, dentists, and other health professionals with disabilities. We'll also be interviewing the researchers and policymakers that drive medicine forward towards real equity and inclusion. I am Peter Poulos, and I am thrilled to bring you the Docs with Disabilities podcast.
Welcome back to the Docs with Disabilities podcast. In this episode, we are joined by Dr. Amy Houtrow. Dr. Houtrow is a pediatric rehabilitation medicine physician, a health services researcher for children with disabilities, and a person with childhood onset disabilities. In this episode, she joins Dr. Poulos to discuss her career path, her research, and her advice for aspiring healthcare providers with disabilities. We start things off with a question from Dr. Poulos.
So my question to you is, in a world where bias against women and physicians with disabilities is so high, you are thriving. Why? What is your secret sauce?
Ooh, what is my secret sauce? My secret sauce is collaboration and engagement with others on things that we're passionate about. I come from a model of medicine which highly values a team-based approach that's goal-directed, uses shared decision-making, in which team members help other team members be the most successful type of provider they could be. So for example, we know nurses help doctors out all the time. Oh, Dr. Houtrow, the patient in room 6 hasn't passed a bowel movement in a couple of days. And that's a cue to me to do something about that. And I become a better doctor when I listen and engage with what other professionals in the field and patients tell me. So I really believe that we're all better together, and that one of the jobs that each of us has as a member of a team is to help the other members of the team be their best selves. And sometimes that means doing little reminders like that example I just gave you with nursing, but I also think it is when we need to be challenged, and when someone has a perspective that's different than ours that can inform us. But I feel like for me, the fact that I have gotten to have a career in which I follow my passion and can do the work that I want to do and feel is valuable has been an essential part of my success. I talk about my career as dedicated to maximizing or optimizing the health function and well-being of children with disabilities. And when I was a very young child, I knew that I would become a doctor, and I wanted to be a doctor for kids like disabilities because I was a kid with disabilities and wanted to be a doctor that helped kids. I didn't even know that pediatric rehabilitation medicine was a subspecialty until I was nearly a 4th year medical student. My stepfather was the OBGYN clerkship director at the medical school where I was in medical school. And there used to be, maybe it was there when you were in medical school also, like this little book that described the different specialties. And my mother was—
The Green Book?
The Green Book, yes. You know it. Yes, my mother was leafing through it and she read the description of pediatric rehabilitation medicine and called me and she said, "Amy, I know what you're going to do when you grow up." And I was like, "Be a doctor?" And because I was in my 3rd year of medical school, she's like, "You're going to be a pediatric rehabilitation medicine doctor." And I was like, "What is that?" So she reads me the description and I was like, that is what I'm going to be. I started medical school, no joke, thinking that I would be a pediatric orthopedic surgeon. I mean, come on.
Wow.
My hands aren't big enough, and neither is my ego. I'm sorry to orthopedic surgeons. Some of them do have big egos.
I was just thinking
And
you're lucky that you didn't, because given your rheumatologic problems now,
right, sure. Yes, it would have been challenging
you
physically
dodged a
for me to
bullet.
do it. Yeah. And then very quickly I figured out that I was not meant to be a surgeon. Very quickly. And then I thought, well, I would do a pediatric residency and become a developmental pediatrician or a child neurologist or something like that. And wow, thank goodness my mother read that in the book. We didn't have a department of rehabilitation medicine where I went to medical school. So I had no exposure to it in medical school until I sought it at another institution. I did an elective in pediatric rehab medicine after I had applied at Cincinnati. I was like, oh, this is where I'm meant to be. And luckily, that's where I ended up. It was one of those amazing serendipities that puts you in the right place.
Bonus is you got to do 2 residencies instead of 1.
Bonus is that I did 2 residencies. I very quickly realized when I was in residency that for me, being a doctor patient by patient wasn't going to be enough. I was and still am shocked and bothered and angry about the hoops families and children have to go through to get what they need to be as healthy as possible. So for me, while I felt like I could do wonderful things and do wonderful things in patient care, patient by patient, that there was a need for something bigger, which is why I was in residency and I sought an MPH in health policy and management while I was doing my residency. And that was supported by the leaders of my residency program and the Children's Hospital that actually financially supported that, and wonderful, amazing mentors that helped guide me. I picked up many more mentors along the way. And the idea that we make change happen at multiple levels, I think, is what drives me, and that I have buttons to push or levers to pull that can influence change and make things better for one child as well as a population of children. And so I think the way to be able to practice your passion is to be in a place where you're supported by a whole host of individuals that are also being encouraged to follow their passions, and that ultimately you're all rowing the boat in the same direction and you all get to shine and do the thing that you've desired to do.
So your first job was at UC San Francisco, right? Out of residency. And I think you started that in 2005 and you were there for 7 years. You left for Pittsburgh in 2012, which is the same year you received your doctorate. You were getting your PhD at the same time you were in your first faculty job at UCSF.
So I had set a precedent for this already. I had done my MPH simultaneously with my combined residencies. So I love learning. And I also love that kind of intellectual discourse that comes from people who are also passionate about what they do and about learning. So I was able to do a MPH while I was completing 2 residencies. I spent 4 days a month in Ann Arbor while I was living in Cincinnati and took classes. I had managed to do that program. And then when I joined the faculty at UCSF, I knew that I wanted to do more research. I had a primarily clinical job, but was very lucky to have protected time for starting a research career, and had an amazing mentor, a man who still mentors me, Paul Newacek, who was really a key person in helping me open doors. He opened them for me and pushed me through them to get opportunities for a whole host of things in the research space. And so I wrote a K-12 application, which is a training grant, which protects 75% of your time. And within my training grant, I wrote in as the training plan the PhD in medical sociology. I knew that I wanted to take classes in qualitative and advanced statistical quantitative analysis, and those were part of the curriculum of the PhD program in medical sociology. Once I started looking at the courses, it became clear that it wasn't going to be that many more courses to get a PhD. And luckily, UCSF, the PhD program there doesn't require a dissertation that is a book, like in many programs. I was able to use published articles that were thematically related. So my contributions to the science, which were part of my K award, also served as my dissertation. So I was able to defend a dissertation based on manuscripts that I had published during my training on my K-12 and during my PhD. It sounds like a big thing to be doing those things simultaneously. It was feasible for me to do it, and I wanted to do it, and I'm really glad I did it. And I met wonderful mentors and lifelong friends through that process.
That's fantastic. I mean, what about your upbringing and education prepared you for this degree of success?
I think that there's a combination of things. I was very lucky to have parents who were realistic about my medical situation and the limitations that imposed upon me, but did not stifle any opportunities for me and actually helped me seek them out and challenged me. And really, as I think all parents tend to do for their children, is help them be successful. And so I'm very lucky to have parents who did that for me. My mother was an amazing advocate. My father is a teacher. I think that learning is, and the desire to do that is in my blood. I went to a very small private school when I was growing up, so I did not have a 504 plan or anything like that. It was all navigable. When I would have surgeries or would be out for whatever health-related reason for an extended period of time, usually related to surgery, I would just make up that work. And it was possible to do that.
In the next section, Dr. Poulos and Dr. Hautrow transition to talk more specifically about Dr. Hautrow's disability and how it impacts her daily life and her clinical work.
Can we talk a little bit more about your disability and how it affects your day-to-day life?
I have a very rare genetic condition. It's an X-linked dominant condition called chondrodystrophia calcificans congenita. So with that, I have pretty substantial scoliosis and restrictive lung disease from that, and then other kind of joint and musculoskeletal problems, as well as hearing impairment from conductive bony changes, cataracts that don't terribly affect my vision yet, and the typical visual impairment that's totally correctable by glasses, which is great because I love fabulous glasses, as you can tell.
And I love your fabulous glasses.
Yeah, my limitations are mostly about being short and having to be more careful physically with a whole bunch of tasks. But actually, it was COVID that has imposed kind of the biggest limitation for me. Because of my restrictive lung disease, I've been careful for a number of years about infectious illness like the flu, and I'm very careful about that over the last several years. And then COVID, because I also take anti-TNF alpha inhibitor for arthritis medication, because I also happen to have an inflammatory arthritis.
So how does it impact your day-to-day work? How do you get around?
So I'm ambulatory, and so I walk around. And stairs, man, I think my arthritis pain is what's the most limiting part of stairs, but I have a lot of joint laxity as well. So much more at risk for, joint subluxation and that sort of thing. But the past 2 years have been much more like, this is my getting around is on Zoom, because I'm trying to avoid getting COVID, because I have really restrictive lung disease. So I've been going to clinic wearing a special individual PAPR system that allows me to go into clinic more safely. My lung disease is severe enough that I can't wear a well-fitting N95 for a prolonged period of time because overcoming the resistance of the mask.
Oh, wow. Yeah.
Respiratory effort. And I think there's a lot of individuals that have that. So people who can't mount as much of an inspiratory effort from spinal cord injury or neuromuscular disease.
We now transition to a discussion of Dr. Hautrau's interests as a researcher. Listen or read along as we begin by exploring the focus of Dr. Hautrau's PhD thesis.
So I want to ask you more about your thesis. This was Children with Disabilities and Impacts on Families.
Yeah.
What about your own experiences inspired the paper, and what did your research find?
My parents used to drive me 12 hours each way to get to the specialty surgery care that I needed. And my dad was a teacher. My mom was a stay-at-home mom. So that meant there was not a ton of financial resources, but my dad had good insurance from being a teacher. And it's an incredible amount of, extra effort to do that kind of travel and make those kind of trips. And I was very lucky that my family was capable of doing that and was resourced adequately to do so. And that's certainly not true for all families. And I would also say that, my parents learned advocacy skills by having to advocate for me. My mother became a social worker. She went to graduate school, during my childhood. I think potentially in part because she had become an advocate. And I also think that society paints the dedication that parents of children with disabilities have as having experienced an incredible burden. And so you read the word impact, and much of the literature is about burden, caregiver burden. That literature exists from Alzheimer's caregivers all the way down to neonates after being born extremely premature, the burden on families. And I did want to recast that with still acknowledging that the way society does or does not, and the way the healthcare system does or does not adequately support families can mean that some of these experiences are incredibly burdensome. So financial and time burdens are real. There can be an incredible emotional strain and distress as well, but there are clearly obvious positive experiences and impacts. So I wanted to investigate that further. One of the projects that came out of that thesis, which was really interesting and somewhat eye-opening, was an examination of the impacts of severe mental health problems that children had on their parents. And as you might anticipate, the more severe the mental health problem, the more impact on the family. But what was interesting is the way families perceived that impact was different. Minoritized families felt less burden than white families and more well-off families. And we weren't necessarily making any hypotheses about that in the paper, but once we discovered that in the data, we started to make some hypotheses about that, which perhaps there's something about the overall societal burdens or stresses that families have, so that if you're a well-off white family, your child's mental health problems are just the biggest thing in the room, right? And they take up all the space. But if you are financially, socioeconomically disadvantaged, and if you're from an oppressed minority group, there's a whole host of things that are stressors for you that are related to just being able to get through living, like making sure that the lights stay on and that you pay your rent and that there's food on the table and that, you're not being discriminated against in your job because you're a minoritized family member. And so that your child's mental health problems, while they might be severe, aren't the only thing in the room. And that, in our discussions about that really was important for me to start to reframe my understanding or or crystallize my understanding about how we think about things in isolation and how important it is not to think about things in isolation. And I do love qualitative research because you can get at so many pieces of someone's lived experience through talking about it with them and hearing them explain it and not making assumptions. But the other pieces about that project that I think were really insightful was some of it was that I was coming in with a little bit of a political goal. So we did a study where we looked at whether or not individuals who had cerebral palsy were at higher risk for having a hospitalization or an emergency room visit if their caregiver was a family caregiver versus like an unpaid attendant from an agency caregiver. And there's no difference. So that I think is good indication that families can be paid caregivers in homes, and they often want to be. And that was through a demonstration project that had happened in California. But I shared that data on the Hill and helped push through for other states the idea that you can pay families. And this is a huge issue right now because we have a workforce shortage for in-home supportive services, and families deserve to be paid for the work that they're doing. And so we could do something pretty phenomenal by helping lift people out of poverty, appreciating and appropriately paying them for the work, and getting people the care that they need and deserve.
Oh, it's absolutely a game changer.
Yep.
Let's go back to this idea about, can we call them more entitled families who feel like, do they feel like they deserve, or they deserve to have a completely healthy child? Do they feel like this is something that wasn't supposed to happen? I ask this because I think for me, part of my difficulty with accepting my own spinal cord injury was feeling like I didn't deserve it.
Isn't that interesting? I will tell you, I was in residency when I developed my inflammatory arthritis. And it took me a long time to, deal with that emotionally. I was very angry. I was like, don't I have enough? Isn't it enough to already have this exceptionally rare genetic condition that impacts my life in the way that it does? Can't I not have this too? And so I can't really answer your question because these answers were given in survey form. But I do think there's something real about the sense of loss that parents often have and grief when their child is either not born typical, if they have a genetic condition, or if they're born severely premature and have consequences related to prematurity. And that's like a natural thing. My own mother spent years, maybe still, feels a little bit guilty, even though there was nothing she could have done to have prevented this genetic condition from happening to me. There was no way they could have known that it was going to happen. And yet, I think maternal guilt is a real phenomenon. But I think the sense of loss and grief is common, and I see that in my own clinical practice. And I think one of the things we can do as professionals working in the childhood disability space and the adult disability space is working on framing things from a strength-based perspective and promotion of goals that are important, and fostering a good sense of autonomy and sense of self and self-actualization, because I think that's what we want, for all children. And, one of the pillars of Maslow's hierarchies of need to get to self-actualization is love and belonging. That sits on top of the pillars that are around the basic things like security and food and housing and shelter and that sort of thing, which are often not equally available to members of our society, unfortunately, which is an area that I spend a lot of research time now in, and working to try to promote health equity so that we can really help children with disabilities who are multiply marginalized have the same access to opportunities for good health as everyone else.
In your research on the interaction of families with the health system and social factors, I read that you uncovered disparities that have really large policy implications. Can you tell me more about this?
Yeah, I think it's a lot of what we just talked about, but I also think that it's kind of a more global statement, which is that often the idea of people with disabilities being a minority group that is experiencing disparities is not front and center in people's minds. And I think that is multifactorial. One, the way disability and health are intertwined with each other. The expectation then, of course, is then if you have a disability, you're automatically going to be less healthy, which in many circumstances is absolutely the case because the nature of the condition that's associated with the disability is something that makes you quote unquote less healthy. But you can have, let's say, an amputation and be exceptionally healthy and really not need all that much extra medical care, especially in your adulthood when you're not needing a lot of additional management for your residual limb or prostheses or things like that. So first, I think there's this automatic assumption that, of course, people with disabilities should be less healthy, which isn't always right. And there's another kind of pervasive assumption that, that people with disabilities are frankly less worthy than others. I mean, this idea of pervasive ableism throughout our society that, medicine does not escape. And so I don't think it was so much that the work that I was doing is particularly groundbreaking, but it was helping like peel back the layers of the onion and so that we can actually look and see and then do something about it. Practically a quarter of adults have some kind of disability. Obviously, as you advance in age, you're more likely to have disabilities, but we're not talking about that same percentage in children, and children tend to get less attention from health policy anyway. And so therefore, children with disabilities get even less attention. So I think that statement is more about us bringing something to the opportunity to get the policy attention it deserves. And certainly, I think much of my work is about looking at those issues. So trends in childhood disability, in differences by minoritized racial group, and differences by income, and a pretty stark increase in neurodevelopmental and mental health related disabilities for kids that I think we're going to continue to see. We're getting ready to do that next set of analysis for 2010 to 2020.
That's surprising to me that pediatric disparities receive less attention than adult.
Well, children do not have the AARP to lobby on their behalf. I'm only sort of kidding, right? So children don't vote.
But their parents do.
But their parents, yes, certainly their parents do. But their parents probably vote less frequently, and they don't have a lobbying group in the same way as older Americans do. There is an incredible difference in the amount of resources that we put towards someone towards the end of their life versus at the beginning of their life. The 80-20 rule, we'll spend 80% of your dollars in the last 20% of your lifespan. Like that 80-20 rule works for a lot of things, but we actually spend a substantial amount of money at the end of someone's life. And I think our society has, and our healthcare system, if I may be critical, undervalues activities for prevention and promotion of well-being and health on the outset. We act in a much more responsive or reactionary way when we could be much more proactive in our strategies to promote wellness. And one of those proactive things that we would be doing is really addressing the base or fundamental impacts that drive people towards poor health, like poverty and oppression, which, poverty is both a cause and a consequence of disability. Disability is both a cause and a consequence of poverty.
In the next section, Dr. Hautrow reflects on her experiences as a speaker during the Stanford Conference on Disability in Healthcare and Medicine, which was organized earlier this year by Dr. Poulos and the Stanford Medicine Alliance for Disability Inclusion and Equity. During the conference, Dr. Hautrow was joined by Dr. Clarissa Kripke for a conversation about transitioning youth with disabilities to adult-based care and services. Listen or read along as Dr. Hautrow shares her experiences at the conference.
The conference was really great, and it was great to have Clarissa and get to talk to her again, because we did work together at UCSF, and I really enjoy those panel discussions. I like it when panelists challenge and push each other, and we come up with hopefully great information that we get to share. And I learned so much, and I really enjoyed having the opportunity to sit amongst those individuals and share and learn. And I also really like the ability to dialogue and have people from the audience share. That was a busy day, but the breakout sessions were great. You must have been beyond exhausted at the end.
Beyond.
Yeah.
Yeah.
I just put on a workshop for 3 afternoons on supporting children with disabilities, lessons learned from the pandemic, and managing just the kind of science side of things was an exhausting process. I cannot imagine all of the logistics that you guys were doing too. But you had a great team, including awesome medical students who were like just so skilled, and that was really lovely.
We had a great team. There's like a ton of people working on that project behind the scenes, starting with an amazing event planner and all of our members, board of directors, medical students, our intern, Lewis, who ran the entire day, him and 2 assistants.
Amazing.
It was really fantastic. So in that conversation you had with Clarissa, you talked about having to see pediatric providers as an adult. And I was just going to ask you what that experience was like, being an adult in a pediatric waiting room, for example, or in clinic. Did it get weird after a while?
I was in residency where there was a really well-renowned pediatric orthopedic surgeon who, I said, hey, I think I should establish care with you while I'm in residency. And that, of course, made sense. And I was still a young adult at the time, and I wasn't facing kind of adult issues like that, over time people develop. So it was still, his expertise were far superior to another orthopedic surgeon with no familiarity.
Uh-huh.
And I, spend a lot of time educating my doctors now, provide them with, a summary so that they aren't caught off guard about, all of the various sundry of things going on with me. When I developed the arthritis, the inflammatory arthritis, I also was in residency at the time, and an amazing rheumatologist was one of my mentors, and basically the person everyone sought out for challenging rheumatologic cases. And when I mean everyone, people from around the country did that too. So I felt very good augmenting my adult rheumatology care with his care. And for me, that felt like the right thing also. And then when I went to go see the geneticist, I actually brought my mother with me. Because I said, there might be things from my early childhood and your pregnancy that I won't know the answer to. And so here I am, the resident, but now in a hospital clinic in California, and it's a genetics clinic. So people, are getting prenatal evaluation. So it wasn't like I was like an adult in the kids' waiting room, but it was very funny to have my mother there. And I did have the resident see me. I didn't not allow that to happen because it wasn't my institution. And so he's, taking this history, and he says, did you have ichthyotic skin when you were born? And I said, no. And my mom says, what's ichthyotic skin? And I was like, oh, like fish scale skin. She's like, you didn't have that. And I was like, I know. I just told him I didn't have it. But a lot of babies with genetic conditions do have ichthyotic skin. And she was like, well, you didn't. You were just the cutest baby.
She's like,
to write that down, right? Defending my cute babiness.
Yes.
But I was really glad to have her there, to fill in any blanks in my knowledge.
The conversation now shifts to consider how Dr. Hautrau's own medical experiences have impacted her perspectives on medical care.
On an early infancy exam, I was this like scrawny, tiny kid. I had a abnormal hip exam, the kind that you're supposed to pick up for hip dysplasia, and that sent me off for X-rays. And the X-rays had all these like stipplings, calcium stipples all over my long bones, which is highly abnormal and nearly indicative of the genetic condition I have.
So probably a radiologist actually made the diagnosis.
Yes, probably a radiologist. And probably that radiologist was like, you guys come over here and see this, which I, of course, became very used to in my childhood because I have a very rare genetic condition. That meant when I went to go see my orthopedic surgeon, that I also went to the special medical photo studio and got pictures taken in my little undies. And I had, when I became a doctor and was in medical school, I was worried that I would show up in one of the textbooks. Like, did I end up in Smith's for a time? I could have, right?
Absolutely.
That kid in there. I mean, I look at the kid in Smith's from the edition that I have from when I was in medical school. It kind of looks a lot like me. It's just very similar features. And also when I would get evaluated by the orthopedic surgeon, it would be in this big room and all the orthopedic residents would just line the room and stand there and watch the exam. And it's interesting now kind of having an understanding of what was happening. So my surgeon, Bob Winter, was a big man, like 6'6" or something, very tall. And he would be on his little stool and he would stand and I would be standing, and he would like put his very large hands on my shoulders and he'd leave them there. And of course, one of the things that he's doing is like checking for all of these asymmetries, right? Shoulder height asymmetry, differences in scapular winging, rib hump, all these kind of things that I now understand as a doctor that are things you can palpate while you have your laying on of hands. But for me as a little kid, I just felt that incredibly comforting that he would, put his hands on me and, talk to my parents and ask me questions. So it is something that I hold very important as a physician myself, is the, laying on of hands and being comforting in that touch. And a lot of people with disabilities, when they're examined, it's very cursory.
Yes.
And for me, it's really important that I, really attend to that person's body and give them the respect that they deserve. And hopefully sometimes some comfort too.
I think that people are recognizing that we've moved too far away from like the laying on of hands and are starting to push us back in that direction and saying maybe less radiology and more physical exam.
As pendulums swing back and forth, I think the really important things that we do is being present. And that might be through the, actual laying on of hands, but you can be present in other ways. I just, did a telehealth visit where I got to watch this child do so many impressive skills. And it didn't require me, laying on physically hands, but I was very present with that child and got to witness incredible developmental progress that child had made since the last time I'd seen them. And I think that, one of the things that we need to have changed in our healthcare system is the ability for physicians and other providers to be able to have the time and the space to be present, to listen, to do caring. And we get pulled so far away from that, whether it's medical records or signing authorizations or doing annual trainings or filling out forms that keep us away from the being present. And it's one of my favorite things that I get to do in my job is just to spend a little bit of time with kids and be present in their lives.
I was just like picturing myself in a classroom, just thinking, God, I pray that my picture doesn't come up in this lecture or in this book. That would be really anxiety provoking.
Right. Well, certainly it was, but then it was going to be like, oh my God, that's my picture. And then I would have to like go buy that book. So the thing about my surgeon, Dr. Winter, is his daughter became a pediatric developmental pediatrician. And she was an attending when I was a resident at Cincinnati Children's. And she, like her father, is very tall. And I was like, could this possibly be my surgeon's daughter? So I went and I asked her, and I was like, is your dad an orthopedic surgeon? And she's like, oh, yes. And I'm like, well, he was my doctor. So well into his retirement, I got to have dinner with him at her house. And it was just so incredibly lovely. Hopefully it was lovely for him as well. It was definitely an amazing thing for me.
Oh, it's so heartwarming. I love it.
Yes.
In the next section, Dr. Houtrow shares her thoughts on how to address the need for more physicians who are interested in and trained to care for patients with complex disabilities.
In that conversation with Clarissa, you also talked about the lack of providers who desire to take care of patients with complex disabilities. My question is, how can we inspire more people to work with these kind of patients, and what role do providers with disabilities play?
So I think that there needs to be a response that's not just focused on how do we convince doctors to do this kind of work. The reason I think that that will fall short is because there are a whole bunch of perverse incentives that keep providers from doing things the way they might want to or choose to or would if they could. So I'm going to give you an example. Most children with disabilities are covered by Medicaid. Medicaid reimburses at a much lower rate than commercial insurance. Pediatricians have appointment slots that may be 15 or 20 minutes long. So a child with disabilities is likely going to take more time to go through their healthcare needs than what's available in a 15 or 20-minute slot. And you're going to be reimbursed less. So if you're a pediatrician trying to keep your practice running as efficiently as possible to be able to hire the staff that you need to do registration, the nurses and whatnot, then the incentive for you is to not see kids with disabilities because you're going to have a smoother running practice and make more money if you cherry pick commercial insurance for kids and for kids who are relatively healthy, right? That don't have a lot going on medically. So even if a pediatrician is like, I'm happy to do that. I took care of these kids when I was in residency. I, felt that it was very rewarding and a wonderful part of my training. They might think that, but the structures around how you practice medicine are such that you are often disincentivized to do it. So I think that there is more to the kind of let's train doctors to do this well. And there's more about system reform to allow doctors to have people with disabilities as an expected, anticipated, and frankly, desirable part of their practice. We all want to be intellectually challenged. We also all want to be able to do great things on behalf of our patients, right? It is incredibly rewarding for me as a pediatric rehabilitation medicine physician to help a child develop their mobility skills, make accommodations where they're needed, get assistive technologies or DME that allow them to be mobile as they desire. That, of course, requires a whole host of factors and people and resources to be available at my disposal to help make that possible. And that's because I work in a quaternary care medical center that has the infrastructure that allows us to make these things happen, and I can spend 50 minutes with the patient, and I have social workers and case managers and nurse coordinators to help make these things possible. And similarly, I think other pediatric providers and other healthcare providers in general, if they were empowered to help make great change on behalf of their patients, to help their patients meet their health and functioning goals, then they would be much more inclined and desire to take care of the full spectrum of individuals in society, people who have very complex healthcare needs and people who don't. But that's not the way the world is set up for us. So certainly I do feel like we have to address ableism in medicine. I do feel like we need to impart knowledge and wisdom and experience of how to address an individual with very complicated healthcare needs as a whole person and not just their body systems that are maybe malfunctioning in some way. Yes, we have to do all of that, but I also think that we have to redesign the system to value what is important for people's health, and that providers then can work in a system that facilitates instead of hinders that.
Is it capitalism that's slightly to blame for this?
We are, of course, the only Western industrialized country that treats healthcare as a good, a commodity that's, tradable on the market. What's happening with primary care offices around the country being bought up by private equity, nursing homes being bought up by private equity, care in those nursing homes deteriorating substantially, then selling them off for pieces and parts and dismantling the whole facility. I want people to be able to live successfully in their homes with the appropriate supports, but I don't want it to be under the circumstances in which private equity is destroying the only place that people can get care. So certainly I believe that we should be working on a nationalized, government-sponsored healthcare delivery system for everyone. I am constantly bothered by the realities that insurance companies impose upon individuals who need imaging, for example, or equipment, and the kind of hoops people have to jump through and that providers have to jump through to make sure someone can get that. The story I often tell is I had a child in my practice who was paralyzed and so needed a wheelchair for mobility. And they went to our durable medical equipment clinic and got evaluated for their custom wheelchair. And I signed all the paperwork and we sent it all in, and the wheels of the wheelchair were denied. So that's a very expensive chair that doesn't serve the purpose of mobility. And I had to do a peer-to-peer for that, which means that I had to take all this extra time, go back to that child's chart, gather all the data, and get ready to have a conversation with someone who's clearly not my peer on the insurance side, go through a chain of different people on the insurance phone line to get to the person who's eventually going to, in this case, luckily approve the wheels. But that's ridiculous. It's just incredibly ridiculous. I had another child who was in my clinic, and I work in Pittsburgh, which is very close to Ohio and West Virginia. And this child was not from Pennsylvania, was from Ohio, but we were the closest place to get care. And he needed Doppler studies because I was concerned that he had a DVT. We thought it was serious enough that he would likely need to, be admitted, but I didn't want to admit him if he didn't have a DVT. So, and I spent in clinic an hour and 15 minutes getting Ohio Medicaid to approve just simple Doppler studies. I was like, we have to get this done. We got to get it done now. I need to do this during business hours. You don't want me to admit this child. That costs a whole lot more money. It's unnecessary if these are negative. These kind of administrative barriers, right, which are driven by insurance companies being publicly traded companies for which they're beholden to stakeholders, not to patients, is problematic. Dr. Glaucoma Flecken is telling us every day in his skits where he tries to get things authorized. I recommend watching them if you're a physician because it's a much needed laugh.
We end this episode, as usual, with Dr. Hautrau's advice for aspiring health professionals.
Do you have any advice for young people with disabilities who want to pursue careers in the health professions?
I have so much advice. We don't have time for me to go through it all. So I had started this conversation with you about passion. And I think if you have the passion for it, then my advice is to pursue that passion. And even though sometimes barriers seem unsurmountable, the way I think about this from my rehab thinking brain, which is that sometimes it feels unsurmountable to like get over the wall because you're trying to climb it. And maybe there's a way where you tunnel underneath the wall, or you take a more circuitous route and go around the wall. Maybe you need some sort of hovering device to float you over the wall, right? But for many people with disabilities, the path to their passion isn't a straight line in the way it can be for people who don't have disabilities. The pathway is more evenly paved and easier to traverse. But for me, it was totally worthwhile for me to pursue and navigate through the challenges. And so, with passion, I think that many things are achievable when at first glance they don't seem to be. My other pieces of advice are about, knowing your true self and, trusting in your strengths and your capabilities and finding individuals who can be champions for you. I said at the beginning of this how important mentors were for me and other people and how interdependent and interconnected we are. And certainly that is true. That certainly true also for people without disabilities, but having people who mentor and sponsor and care about your path are exceptionally important. And so seek them and find them. I will also say mentoring has been one of the greatest joys of my career, whether that's mentoring somebody at the beginning of their journey or their career or peer mentoring. I find it an incredibly enriching and rewarding relationship to have with people that I am mentoring. And so finding those people, if you are a person with disabilities, finding people who will champion for you, I think can be really very helpful. And, we talk a lot about the extra work and effort that people with disabilities don't necessarily see that we're doing. And you may hear that, and this happened to me, oh, you're so lucky. You got to bring a footrest and a cushion in to take your board exams. It's like, because my feet don't touch the floor in a chair, right? Oh, you're so lucky.
Yeah.
So I think that's just a very kind of naive understanding of the circumstances of disability. I mean, people who have disabilities joke about this, all the time when someone says, oh, you're so lucky. You have a handicap placard.
Yeah.
Like you get to park at the front of the grocery store.
Woo-hoo.
I mean, lucky. You're so lucky. Which is such a limited understanding of the disability experience. So I do think that there is this expectation in medicine that you're really pretty invincible, and humans aren't invincible, and our vulnerabilities make us better people. So I think that those of us who have disabilities are incredibly added value to health disciplines, and we need help potentially, as do many, to be able to thrive. The system needs to be set up in a way that helps us thrive, and that can be through accommodations and through sponsorships and through recognition and all of those different ways, and working towards a kind of anti-ableist agenda in healthcare, which I think is a multi-generational kind of strategy that we need to take and shouldn't stop someone right now who has disabilities from thinking about entering into medicine. I mean, another kind of truism is that we really can't let perfect be the enemy of the good. And so some things won't be perfect, and we might not achieve exactly how we thought we might achieve. And our disabilities might shape our trajectories somewhat, or our opportunities. And there's still so much wonderful things out there to be contributing and doing. So it's a lot of encouragement that I have for people entering the field.
Thank you. Thank you. I'm sure our listeners will appreciate that. Our conversation has inspired me. Notice that I did not say you are inspirational. I'm just saying our conversation has inspired me, because no, it's just rejuvenating to talk to somebody who has such passion about their work, and I enjoy it. And I enjoy you.
Ditto to you. I'm so impressed with what you've been doing, and glad to have gotten to meet you.
To our guest, Dr. Hauchow, thank you so much for joining us for this episode. We're so grateful for the work you do every day and for your willingness to share your expertise with our audience in this conversation. To our audience, thank you so much for joining us for this episode. If you have not done so already, we encourage you to subscribe to our podcast so that you never miss an episode. We also strongly recommend that you check out our new mini-cast, Research and Resource Rounds, where we review research articles and critical commentaries about disability inclusion and health professions education in 15 minutes or less. This podcast is a production of the Docs with Disabilities Initiative and is supported in part by the University of Michigan Medical School Department of Family Medicine and Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, the respective institutions, or the funders. This podcast is released under Creative Commons Attribution Non-Commercial Non-Derivative License. This episode was produced by Sophia Schlossman and Lisa Meeks with support from our audio editor, Jacob Feeman.